Hey there, my name is Dr. Kayla White, and today I'm going to be discussing primary hypertension. So, in looking at primary hypertension, there are various mechanisms described for the development of hypertension, which includes increased salt absorption, resulting in volume expansion and impaired response of your renin-angiotensin-aldosterone system or your RAS system, and increased activation of sympathetic nervous system. These changes lead to the development of increased total peripheral resistance and increased afterload, which in turn leads to the development of hypertension. The current definition of hypertension is systolic blood pressure or SBP values of 130 or more, and a diastolic blood pressure or DBP more than 80. Looking at assessment findings, most cases of hypertension are asymptomatic and are diagnosed incidentally on blood pressure recordings or measurements. The ACC recommends at least 2 office measurements on at least 2 separate occasions to diagnose hypertension. Physical examination may be unyielding other than occasional pedal edema or raised blood pressure, but one needs to look for signs of possible aortic valve disease. You could hear that systolic ejection murmur or fourth heart sound. Renovascular disease or fibromuscular dysplasia. You could hear a renal bruit, a carotid bruit. Polycystic kidneys, you could have enlarged kidneys bilaterally. Endocrine disorders, hypercorticolism, thin skin, easy bruising, hyperglycemia, and then thyroid disorders, palpable, painful, or enlarged thyroid. As I stated previously, the ACC recommends at least 2 office measurements on at least 2 separate occasions to diagnose hypertension. Ambulatory blood pressure measurement is the most accurate method to diagnose hypertension and also aids in identifying individuals with masked hypertension as well as the white coat effect. The evaluation consists of looking for signs of end organ damage and consists of looking at these different things: a 12-lead ECG. You can document left ventricular hypertrophy or cardiac rate, rhythm. Fundoscopy to look for retinopathy, maculopathy. Blood workup including your complete blood count, ESR, creatinine, GFR, electrolytes, your A1C, thyroid profile, blood cholesterol levels, and then your uric acid. Urine albumin to creatinine ratio. Ankle brachial pressure index or ABI if symptoms suggestive of peripheral arterial disease. And then imaging included your carotid Doppler, ultrasound, echo to look at your heart, and brain imaging when it's clinically deemed feasible. So staging of hypertension, classification and stages of hypertension are defined in recent American College of Cardiology, ACC guidelines. Normal is systolic blood pressure less than 120 and diastolic blood pressure less than 80. Elevated is when your systolic blood pressure is 120 to 129 and diastolic blood pressure is less than 80. Stage 1 hypertension is systolic blood pressure 130 to 139 or diastolic blood pressure 80 to 89. And stage 2 hypertension is when your systolic blood pressure is greater than or equal to 140 or greater than or equal to 90 for the diastolic. Looking at the pharmacological treatments, you can use ACE inhibitors, angiotensin-converting enzyme inhibitors, angiotensin receptor blockers or ARBs, diuretics, usually thiazides, calcium channel blockers, and or beta blockers. Non-pharmacological treatments for hypertension, patient education is paramount to effective management. It always needs to include weight management, salt restriction, smoking management or cessation, adequate management of obstructive sleep apnea, and exercise. Weight reduction is advisable if obesity is present. Weight reduction alone can result in the decrease of up to 5 to 20 millimeters of mercury in systolic blood pressure. Lifestyle changes alone can account for up to 15% reduction in all cardiovascular related events.